We are live.
Very good evening to one and all. Today we have two experts with us to discuss a very niche topic in hematology and rheumatology combined. This is how these experts treat and diagnose HLH, particularly in adult patients. Our first speaker today is Dr. Jessica Manson, who is a consultant rheumatologist at University College London Hospitals. She leads the UK's multi-speciality HLH service, and she has also co-founded the Histiocytosis and Hyperinflammatory Disorders Across Specialties Collective. She leads research in translational research in multiple hyperinflammation-related research questions. It's an honor to have you here, ma'am. Today, we are lucky to have not one, but two speakers with us. Our second speaker is Dr. Satyen Gohil. And Dr. Gohil is also consultant hematologist at University College London Hospitals. His areas of expertise include chronic lymphocytic leukemia and HLH. Dr. Gohil leads the National HLH multidisciplinary team at the center and is also the chief investigator for national HLH and lymphoma trials there. We are privileged to have both of you here with us. This is our team of hematologists, hematopathologists, critical care physicians, and nursing team that take care of patients with hematology needs in Gurgaon. And this team, led by Dr. Rahul, makes this informative session possible. Um, Now, shall we proceed ahead with the session, Dr. Rahul? All right.
Yeah, I think
So,
Anusha, we are good to.
okay. All right. So, adult HLH is one of the most challenging areas in hematology practice. Unlike pediatric HLH, where genetic causes are the most common etiology and standardized protocols exist, which all gives us a very big source of comfort when we know we are adhering to very strict written protocols. Adult HLH, by virtue of its nature, is highly heterogeneous, can be triggered by infections, malignancies, autoimmune disorders, or sometimes even the therapies given for each of these diagnoses, making it extremely complex to both diagnose and treat. And to make matters one layer more complex, the clinical features often mimic both sepsis and multi organ dysfunction, sometimes leading to delay in both recognition of the diagnosis and treatment. Um, Treating it again is a big story of balancing immunosuppression, whether to give the patients further chemotherapy, biological therapy, and supportive care, all while looking for an underlying trigger which has caused the entire storm. And sometimes outcomes heavily depend on whether you have an early clinical suspicion and we pick up such things. And I think because of all these complexities, it makes it very important that we hear from experts who see particularly HLH day in and day out. And we are honored to have both of our speakers here. Thank you very much for sparing some time to talk to us today. Over to you, Dr. Manson and Dr. Gohil.
Thank you so
Hi.
much, Anusha. That's great, and you've saved me some work because you've done such a brilliant introduction that I don't need to do my first and second slide. Right, let me just share my screen again, if I may. Can I just check with somebody that you can see the slides, please?
Screen is visible, okay, ma'am.
Great, thank you so much. So as Dr. Anusha says, I'm a rheumatology consultant, and Sat, Gohil and I are going to do a sort of 50-50 today. So I'll start talking a bit about how we diagnose HLH, which as Dr. Anusha's also already alluded to is hard enough in itself. And then Sat, Gohil will talk a bit about how we try to approach the management of these patients. So as I just said, really this slide is not needed, except to just introduce this first concept that we use to raise the awareness of HLH, which is this idea of the 3 Fs. So these patients present with a constellation of symptoms that almost always include fever in association with falling blood counts and high ferritin. And a lot of the education that we've done across the UK has been really to raise awareness of this concept, and such that any unwell patient in hospital, the question of HLH is raised, and the initial trigger is to recognise whether they do or don't have these features of the 3Fs. So the reason that we do this work is because outcome is so horrendous still in HLH. So overall, the UK mortality is about 50%, and that goes up as high as more like 80% in patients with associated hematological malignancy. Dr. Anusha already alluded to the causes of HLH. So in children, often, it is a primary genetic mutation. We're increasingly recognizing these mutations, however, in adults also. And in adult practice in the UK, cancer, particularly lymphoma and leukemia, are the most common drivers. We also see a lot of infection. In rheumatological disease, we're talking about lupus and Still's disease. And then there's this miscellany of other causes. We've just published a case series of women who have pregnancy-associated HLH, a couple of cases of patients with lamotrigine-associated HLH. So really anything that irritates the immune system can do it. So why do I do this work? So this began really fairly early on in my career. I've been working here for now 15 years, but in the first 5 or 10 years, I came across this young man who was 25 years old, and apart from being in prison, which is not very good for you, he was otherwise very well. And he'd presented to a local hospital with rash, fever, joint pain, sore throat, and chest pain. And his initial presentation actually was thought just to be a viral infection, and he was sent home. Then he was brought back again to our tertiary centre, more unwell, and this time was also noted to have moderately avid on imaging, widespread lymphadenopathy and hepatomegaly. He was also noted over the first few days of his admission to have progressively worsening cytopenias, which had started with a mild thrombocytopenia. And he was becoming increasingly unwell with this febrile illness. He initially came in under the infection doctors, who then asked the hematology doctors to see him, who then asked me to see him. And there was a lot of different teams involved. There was a lot of discussion about him. We were all worried about him, but none of us quite knew what to do with him. And I was very much struck at the time by a conversation with a very certain cardiologist who said to me, well, Jess, this is the echo of sepsis. This man has sepsis, you just haven't found the bug yet. And while all these conversations were happening, this previously completely well man rapidly deteriorated and ended up on critical care, needing organ support, and really had a prolonged admission. And by the end of that admission, it became clear that he actually had onset Still's disease, complicated by HLH, but it took a long time and it just didn't feel like good medicine. So after this, I thought to myself, what is it that's making me uncomfortable? And one of the feelings was that these patients didn't have a home, and there was a risk of a rheumatologist coming along and saying, well, it's not lupus, so it's not my problem, and a hematologist coming along and saying, well, it's not lymphoma, so it's not my problem, and so on. And it was clear to me that we needed to work across specialty and give these patients a safe place to be. And the second problem was that outside of the key specialists, and we were quite late in a way to the conversation, no one had actually heard of HLH. And there was also this other problem that rheumatologists called it macrophage activation syndrome. And even if people had heard of it or they'd gone away and done a literature search, there was then a great fear about using immune suppression in the context of somebody who looked like they were septic. So it seemed to me that we needed to work better across specialties, but also really work very hard to raise awareness of the condition. And so over the next couple of years, a few things happened to improve the resource for UK doctors and therefore patients for people with HLH. So the first thing was Dr. Anusha, you already mentioned, that an organisation called HIHASC. So this I established with a colleague in Sheffield who's a paediatric and adolescent rheumatologist. And HIHASC really had 4 main aims. The first was really to improve care by sharing clinical learning. So in spite of us seeing a lot of HLH here, it's still not more than about 30 patients a year in-house. And we felt that we needed to take on this mantra of learning from every patient and sharing learning across sites. The second was to develop a research network, and we've had some money to help do that, to buy a bank and do some epidemiology and biology in these patients. The third was to link to patient groups. So we're actually linked to a small British charity for patients with HLH and their families. And the fourth was to influence government policy and really say we need access to HLH, important drugs for HLH and care for HLH across the UK. So we now have more than 300 members. It's actually very international. So if you're interested afterwards, please let me know, and we'd be very delighted to welcome you. And we have across age groups, so paediatric adult physicians, and across all specialties. So in parallel with that, a few months later, we established the UK HLH network. So this is actually a clinical service. And this has grown hugely from when it first started in 2019, when we would discuss about 4 patients a month in a single monthly meeting. And that has now gone to 6 patients a month. Both of the national advisory panels are Teams-led meetings. They're actually rheumatology-led, but that's not important there. The important thing is that each meeting is supported by rheumatology, hematology, infectious diseases, critical care, and often neurology. And across the UK, we've agreed a set of guidelines on how to approach these patients. And we've really agreed to focus a lot on the training of doctors and nurses who might come into contact with patients who could have HLH. And this is the sort of amount of work that we're now doing. So between us, Sat and I look after sort of between 30 and 40 patients a year, most years. That first black arrow is where our service became established. So partly the reason for the jump was that COVID induced HLH, and partly we were raising awareness and also importing patients into our hospital from other smaller hospitals. We've actually started now encouraging the management of patients in their own hospitals, and that accounts for the slight reduction from 2023 to 2024. So we have the inpatient service, but we also, as I said, have these multidisciplinary team meetings where we advise on the management of patients who are not in our own hospital. And this went from fewer than 20 discussions in the first year to more than 200 last year. And we still have a lot of work to do, unfortunately. So as you'll see, the mortality from HLH at UCLH remains unacceptably high, although the outcome has improved since we've been working in this joined up way. And really the whole idea of the network and of HIHASC is to embed in routine clinical practice this concept that any doctor who comes into contact with unwell patients from any specialty needs to recognise where HLH is possible. And this led to the development of 2 things. The first on the left is a pathway called Getting It Right First Time. So the UK Health Service has some sort of agreed standards, and this is freely accessible information for any doctor, in fact, wherever they are in the world, to think about how you might approach a possible patient. And a year or so before that, we published a guideline in Lancet Rheumatology. So really the whole basis of that is to say, what do you actually do when you're a clinician on the ward and you see an unwell febrile patient? The first question that we have to embed is the idea that this could possibly be HLH. And so how do we go about doing that? So that comes back to this idea of the 3 Fs. So this is fever, rising ferritin, and falling blood counts. Often the counts can be normal to start with, so it's important to watch the trend. And then if you recognise that a patient might have HLH because of those 3 indicators, then in a moment I'll take you through the H score. So we recommend bloods for a quick HLH screen, and you can either use the 2004 criteria or the H score to help you assess the likelihood of your patient having HLH. And then in parallel, you're also working up to try and understand, why does this patient have HLH? Because we understand that treating the driver is also very important. And then your third parallel stream is to assess for the degree of organ involvement. So this is the H score, which is readily available on all MedCalc equivalent calculators. And importantly, these are not expensive or difficult to access tests, although having said that, it took me about 5 years to get a rapid turnaround for ferritin in our hospital, which was problematic. And obviously you do need the ferritin to be titrated out. So you'll see there's very heavy weighting here for instance, a particularly high fever or the presence of hepatosplenomegaly. To the rheumatologists like me, the issue of trying to get a bone marrow can be difficult, particularly not in my hospital anymore, but particularly, obviously, we may not get this result back during the night, for instance. But it's important to remember that you can calculate an initial H score without evidence, without having a bone marrow aspirate result back, and just do an initial score to give you a feeling. So the H-score output is to give you a percentage probability of HLH, and it's generally accepted that an absolute number cutoff of more than 169 is very high probability. But it's important to repeat if the patient changes, to trust your instincts. So if a patient, for instance, has liver failure and sepsis, then it's very easy for them to meet the HLH the H-score cutoff for HLH, but actually, if we think about it clinically, they don't have H-score HLH, they just have the numbers that make it look like they do. And just remember, of course, that fever can be suppressed if the patient's on a filter or on medicines such as paracetamol. So the first question then is, has this patient got HLH? Do they have the 3Fs? What's their H-score? And then the second question, as I said, is why does this patient have HLH? So this is really a pyrexia of unknown origin workup. Rheumatological diseases often show themselves with a combination of, a good review of systems, history taking, examination, and immunology. Infections often show themselves with good microbiology and virology. And what we've learned is that lymphomas in this context can really hide. So we have got used to doing multiple go rounds of biopsying any abnormal tissue and looking for unusual forms of lymphoma, such as intravascular lymphoma. And really important to identify these patients, because without aggressive treatment of the lymphoma, the HLH will return and their outlook is pretty bleak. So then the third question is, how unwell is your patient? And we have become increasingly respectful and fearful of HLH and really try to get all of our patients onto critical care if at all possible. Certainly when we're transferring them between hospitals, we always ensure there's a real focus on safe transfer. We have become very aware of this sudden cardiac death related to HLH, which I think is probably due directly to the cytokine storm. So we have a very low threshold. We would do an echo on everybody in a low threshold to repeat the echo if they're tachycardic. The median age in our cohort is about 40. The patients are typically really quite well until they come into hospital. So they're able to cope with quite a lot of cardiovascular strain until they aren't able to cope anymore. So it's really important to understand what their function actually is, as opposed to how they look from the end of the bed. We're also very mindful of neurological deterioration, and confusion often is an early sign that the patient's going to become more unwell. And just to repeat, as I said before, have a very low threshold for ICU and HDU. So I'm going to stop sharing there and hand over to Sat, and I think we're going to do questions at the end. Thank you.
Perfect. Thanks very much. Let me try and share my screen now. Okay, so thanks very much, Jess, for that introduction, and thank you all for having us give this talk. So I'm a hematologist, and I sit on the panel, and this is one of the index cases I was first involved with when I started working with Jess in HLH. So it's a 28-year-old female accountant, originally from India, but had been in the UK for around a year, married with a one-year-old child. Past medical history was significant for multiple sclerosis, which was treated, and a muscular dystrophy, which was very mild. And then she presented in December of 2021 with daily fevers up to 40. And at this stage, people thought it was just a viral infection, it would settle down. But then she was readmitted and met the criteria for HLH. And this at her local centre was managed with steroids, rapidly improved, and then was discharged. As soon as the steroids were weaned, she had a further admission, which was all triggered by the steroids coming down. And she had all the characteristic features of HLH: pancytopenia, high ferritin, triglycerides, LDH, and a low fibrinogen. A bone marrow showed hemophagocytosis, which was quite marked, but no evidence of any malignancy. So she went through the whole gamut of treatment. So she had already had steroids. She had IVIG. We gave anakinra initially at 100 milligrams twice a day and increased that to 200 milligrams twice a day. We added in cyclosporin. We gave repeated pulses of methylprednisolone, and she was on and off the intensive care unit. She'd improve, and then she'd just deteriorate. Her CT showed marked hepatosplenomegaly with a mental thickening, and we were so desperate to try and find out the cause that she'd had multiple biopsies, including a liver biopsy, which again showed features of HLH, but with no evidence of malignancy. So she again improved with all of that treatment, and then she was sent home, and then she managed 10 days at home, and then came back to A&E and went to the critical portion of our emergency department with hypotension and lactate of 5. She was started on inotropes, and then we restarted all of the treatment and added in etoposide at this stage. She'd improved with a decrease in the size of the liver and the spleen. The thickened omentum persisted, and we went round in circles trying to figure out whether the omentum was TB because of her history and risk factors. And we kept so it was sort of one step forward, two steps back. And so she was on and off ITU. She'd improve, and then she was readmitted with an SVC. And then we continued the etoposide, but any dose that was delayed, so we gave twice weekly etoposide. As soon as we even delayed the dose of etoposide by 24 hours, it led to a significant flare of her fevers. The addition of cyclosporin didn't do much, and at this stage, the etoposide was losing its efficacy. She'd now been in hospital for 3 solid months, mostly on the intensive care unit, and developed marked ascites and abdominal distension. And this is her fever chart. Daily fevers, often going above 40, despite all of the massive immunosuppression that we'd done. Now, although she was in her late 20s, we did send off a screen for primary HLH, and she did actually have a mutation within the RAB27A gene, and she is a patient who has Griscelli type 2 syndrome. And we are finding these patients more often now. So we are sending off a primary screen in patients who present with HLH pretty much up to the age of 30 to 40, especially if there's no clear cause. The genetics of HLH are still very murky, and I think the more genetic information we have, the better it'll be. But what we were going to do, so that she was really refractory to etoposide, and then what we don't have easy access to in the UK is JAK inhibitors for HLH, but we did manage to convince the drug companies to give us compassionate access to ruxolitinib, and you can see where it was started. If I show you the pointer, as soon as we started the ruxolitinib, these were her fevers pre-ruxolitinib, and as soon as we started the ruxolitinib, there was a dramatic fall. And although she'd been in hospital for 3.5 months at this stage, within a week she was well enough to be rehabilitated and go home. So, and this is just a marker of her liver function. This is her ALK-Phos, and you can see where the ruxolitinib started, there was a dramatic fall off in her ALK-Phos and improvement of her liver dysfunction. So I think, I'm talking to lots of hematologists who know about these drugs, but, in our treatment algorithm that we use, we tend to favor steroids at high doses. So, 500 milligrams to a gram of methylprednisolone. We give that for 3 days, followed by a reduction to a milligram per kilogram of pred or the equivalent dose of methylpred if they can't take tablets. Now, there is, if someone presents with HLH, but you think they've got an underlying lymphoma and you don't want to give steroids, we often use anakinra as a steroid-sparing agent. So anakinra blocks the IL-1 axis and can often suppress the hyperinflammation of HLH to allow you to get a biopsy. Now, if a patient is actively deteriorating and going to the intensive care unit, we still give the steroids. 1 or 2 doses of steroids won't affect the lymph node morphology, and we still get good diagnostic samples, even if patients have had, a good number of days of steroids. It's just if they're stable but slowly deteriorating, you may want to think about anakinra rather than high doses of steroids. But if patients need it, we're very keen that they get steroids early, just to try and dampen everything down, because these patients can deteriorate very rapidly. And then after that, it becomes slightly more complicated, and access is always difficult depending on the centers that you're at. So there is mixed data for the use of intravenous immunoglobulin. So we do have access to it for HLH. Lots of drugs in the UK are fairly tightly rationed, including IVIG, but we do have access to it and we often use it as an adjunct. Cyclosporin is sort of an adjunct that we use. We don't tend to use it as a single agent because it doesn't seem to be immunosuppressive enough. But if you've got someone who, is on, who just need a bit of extra immunosuppression, it's sometimes quite handy to have to give it in the background. And what we have learned is that we are much more pro-etoposide than we were when we initially started. So our threshold for giving etoposide and giving good doses of etoposide is now much lower. We have never regretted really giving etoposide, but we have often regretted not giving it because sometimes you have a window where you can get the etoposide in, and if you miss that window, then sometimes giving it topside later just doesn't lead to the same benefit. And so one of the things that we advocate for much more strongly now is the earlier use of etoposide, because we know that these patients will continue to deteriorate. They have awful prognosis, and so we often recommend etoposide early, especially if you've got a young patient who's got cardiovascular compromise. If they've got cardiovascular compromise, they've got a poor left ventricular ejection fraction, they've got signs of cardiac inflammation because of a rising BNP, rising troponin, and a pericardial effusion, our threshold for using etoposide is much lower than it has been. Now, it's always difficult to dose etoposide, especially in HLH, because there's often a high bilirubin. We try and ignore the bilirubin as much as possible, and we try and give the full dose of etoposide. We tend to go for 150 milligrams per meter squared. If we sometimes reduce it to half or two-thirds if the bilirubin is very high. But the whole reason for trying to give the maximum dose is because the liver is unhappy because of the HLH, and so therefore you want to give the maximum dose that you're allowed to try and calm that down to help bring the liver dysfunction down. Now, I'm talking to lots of hematologists who are very aware that there's lots of HLH has had this revival in terms of people taking interest on it. I think partly because of COVID and all the hyperinflammation that we've seen, but partly because, there's much more education about it. People are much more aware. And previously people said, oh, that patient's just got bad lymphoma. We've now got, now we can say they've got hyperinflammation and, there's things going on. So a few things. So there is a new index called the OHI index, which has come from America, and that uses two markers. One is ferritin, and one is a soluble CD25. Now, soluble CD25 is not the easiest test to get, but it can be useful. So if you've got a hematological malignancy, which is the vast majority of patients with secondary HLH, and you've got a ferritin more than 1,000 and a soluble CD25 more than 3,900, your probability of survival is awful. It really is. It's sort of 10 to 20% at around a year, irrespective of what the hematological malignancy is. But even if your ferritin is over 1,000, and a ferritin of over 1,000 is not actually that high, you can see that your survival is in the region of 40 to 50% at 1 year, which again is just awful for patients with hematological malignancies in this day and age. And sometimes this can be a useful marker of having discussions with families, having knowing how aggressive you want to be. Soluble CD25 tends to be higher in patients with hematological malignancies, and those who have higher soluble CD25s tend to die more often. Patients with infection or autoimmune related HLH tend to have lower levels of soluble CD25 and often do better, which we know from lots of studies. Now, a few things that have often tripped us up or have led to slightly unusual outcomes in our MDT is a few rarer diagnoses. So the first one I'd like to mention is TAFRO. So this is a hyperinflammatory variant of multicentric idiopathic Castleman's disease, and patients can present very similarly with HLH. The TAFRO stands for thrombocytopenia, anascara, fever, reticular fibrosis, and organomegaly. And we've had a couple of patients who present with come to our MDT with, does this patient have HLH? They're not really responding to everything. And, it's just something to bear in mind. The key giveaway for Tafro is that tends to be that patients have lots and lots of effusions, far more effusions than you would see in someone who's just unwell, especially pleural effusions, ascites, and peripheral edema. The other thing that often comes up is Vexus syndrome. And so we now test for the UBA1 gene more frequently. We are much more direct with our pathologist, looking for vacuolation within the bone marrow cells, and trying to see if they have these constellation of symptoms which lead to a diagnosis of Vexus syndrome. But because even with the genetic testing, it can often be a couple of weeks before we get the result of the UBA1 gene sequencing. Something which also comes up is Kikuchi's. So this is a histiocytic necrotizing lymphadenitis, which often presents with lymphadenopathy and can present with a HLH-like picture. Jess and her colleagues see far more of this because of its association with SLE. But this, although it tends to be self-limiting, can lead to a Fulman HLH-type picture. And then we've also seen a couple of cases of chronic active EBV more recently. And this is a chronic EBV infection of T or NK cells. Now, it's distinct from T and NK cell lymphoma, which is the differential diagnosis if you've got a significant EBV infection within your T cells. And the only curative option is an allogeneic bone marrow transplant. But in these patients, it can be very difficult to control the HLH. Rituximab doesn't tend to work because it doesn't target the T cells. And you can often see these patients deteriorating rapidly before your eyes, despite throwing every single immunosuppressive agent that we have. We have one center in the UK which can do a flow-based assay to look to see whether the EBV is within the B cells or the EBV is within the T cells, which is sometimes useful, but again, that's not a test that comes back rapidly. So we can, in the discussion section, we can talk a bit more about, our favored treatment modality, both in the UK and internationally. But one of the most important things is also managing the complications of patients with HLH, because this is where a lot of the morbidity and a lot of the mortality comes from. So we have found that infections are a big driver of both morbidity and mortality in our patients, and we are very, very keen to make sure that patients are on good prophylactic antibiotics, antivirals, and anti-PCP agents to make sure that we try and limit that. Even with this, we do often lose patients with disseminated fungal infections, which can often only be detected post-mortem. The other thing is coagulopathies and cytopenias. So these patients often require lots of blood products. One of the worrying things that I see is a falling fibrinogen, and a fibrinogen which is not responsive to either fibrinogen concentrate or cryoprecipitate. So as soon as you see that the fibrinogen is starting to fall despite everything else, I really do worry. And we're also then thinking about whether we need to escalate, because we have lost patients with large bleeds, both GI bleeds as well as intra-abdominal bleeds. These patients tend to be neutropenic, and we are cautious with the use of GCSF, and it's always a case-by-case basis. There are anecdotal reports that GCSF can lead to a rebound of HLH because it leads to a new wave of neutrophils and further inflammation. But if patients have an active infection, which is proven in the context of HLH, we often do want to try and get the neutrophil count up to try and help fight that infection. So we've gone on, I think Jess has mentioned a couple of times the heart. I'm going to mention the heart again. So we do a BNP, troponin, and echo on all our patients with HLH. They do die of sudden cardiac death or sudden cardiac compromise. The people on our intensive care unit are very good at looking at the heart and trying to differentiate, if this is a more aseptic looking hyperdynamic picture versus a more HLH type picture. And it's all linked to the cytokine storm. There is a paucity of research, and we often re-echo and often try and make sure that we are keeping a very close eye on their heart, because it is a risk factor for them dying. Now, in my case, I mentioned JAK inhibitors, and I think in the UK we are limited with our access to JAK inhibitors, which is not a restriction elsewhere in the world and in the UK. And the JAK inhibitor, which is the most data, is ruxolitinib. So there are a whole host of papers with describing the use of ruxolitinib in the management of HLH, and ASH recommends the use as a in this in as the use of ruxolitinib if a salvage therapy for HLH. But for us, ruxolitinib costs the hospital who's prescribing it about £2,000 a month, which is prohibitive when you're trying to get that funded. So we have tended to use baricitinib at UCLH and a couple of centres around the country now because it's a quarter of the price. And again, it is both a JAK1 and JAK2 inhibitor and blocks most of the same pathways. And JAK inhibitors are very important and very topical because they often block the cytokine storm and are central to on both T cells and monocytes and macrophages as well as NK cells in driving hyperinflammation. So all the JAK molecules are circled in this picture, and so they can be a very useful adjunct or rescue therapy. Now, more recently, for those of you who've seen, there has been a Chinese study published a couple of weeks ago looking at the frontline treatment of ruxolitinib and dexamethasone in patients with HLH. And there are a couple of caveats. Although it made it into the Blood Journal, you can see there's only 28 patients. And despite that, and despite using ruxolitinib early, you can see that for lymphoma-associated HLH, which is the red line, the outcomes are still very poor. And this is a very carefully selected cohort of patients rather than all comers. So despite the use of ruxolitinib, which I think, in the US and around the world is being used slightly earlier, and I wish I had access to it slightly earlier, even with access to it, it's not like it's a magic button which just switches HLH off. There is still a huge unmet need for these patients. So what are other options? So if you're a pediatrician who treats HLH, and especially primary HLH, you will know about emapalumab, which is an anti-interferon gamma monoclonal antibody, which is licensed and approved by the FDA for the treatment of primary HLH. There is some use of emapalumab in secondary HLH where the results are disappointing. So there's a couple of studies which have now come out using emapalumab for secondary HLH, and people thought, great, we've got another agent, but it is very disappointing in its efficacy in secondary HLH, partly because I think interferon gamma is far too down the pathway, and I think the pathobiology of primary HLH is very different to secondary HLH. We also often discuss the use of Campath. Now, Campath is a great agent for killing off your activated immune cells. CD52 is on all the cells you want to target, but you really need an exit strategy if you're going to use Campath. So Campath is great. It will control HLH extremely well, but after about 4 to 6 weeks, you will have a rebound of the HLH when the Campath levels go down, and you really need an exit strategy of where you're going to go after you give Campath. So it's great as a conditioning. It's great to try and bridge people if you're trying to get them to an allogeneic bone marrow transplant. But by itself is often something that we reserve for fairly last ditch measures. The other thing to bear in mind is, I've shown you the data for the RuxDex study from the Chinese group, and there are more clinical trials because I think this is a topical area. So there is a trial using a SERP antagonist. So SERPs provide the don't eat me signal on your immune cells, which allow regulation of what neutrophils and macrophages target. So SERP molecules in HLH are very highly activated and very, very highly expressed. So there is this depleting antibody. It's called ELA-026, and this is going through international phase 2 trials now to look to see if we can have another agent to try and switch off activated T cells and NK cells. With that, all of the work we do in HLH is very hard to do with just me or Jess. We are very, very fortunate that we have an extremely strong team of clinicians who all come together. So we come together every Monday to discuss around 4 patients, and every other Wednesday. So we have 6 meetings a month with 4 to 6 patients in each meeting, for patients around the UK, Ireland, Europe occasionally, and we also had a case from 1 or 2 cases from India presented at our meeting. There's a mixture of rheumatologists, infectious disease, hematologists, virology, critical care, and neurology, because a lot of our patients present with quite marked neurological manifestations. So that is where I'm going to stop. But I think the most important part now is getting to the question and answers.
Yeah. Thank you very much, Dr. Gohil and Dr. Manson. That was a very comprehensive overview of such a difficult topic. I think what resonated with me the most is these patients not having a home, which is very true, where everybody's trying to get a piece of biopsy from somewhere and land up in a diagnosis in a desperate attempt to race against time. Now, with that in context, can we go ahead with the questions that we had collected from our colleagues? Yeah, okay.
Of course.
So most of these questions are probably looking into subgroups of patients who have HLH and anything we would do differently in each of them. Um, Talking about coordinating with other departments, biopsy is an integral part of diagnosis here. And sometimes we look at prominent histiocytes in the biopsy, in the bone marrow especially. Is that significant? And because we get a little excited when we see prominent histiocytes and the rest of the clinical picture is fitting, but we don't have a full-blown hemophagocytosis in the marrow. Is it at all significant? How do you view this?
So I think we it's often great if you see hemophagocytosis, but I think the main reason for doing the bone marrow is not whether they've got hemophagocytosis or not. The main reason for doing a bone marrow is to look to see if there's a lymphoma. That I think is far more important in terms of the bone marrow, because you can get a H score of 169 without needing the bone marrow. The bone marrow in the H score is only 30 odd points, and so for us, the bone marrow is far more important in looking, one, is there a lymphoma? Is there TB? Is there another infection that's going on? Now, we often see patients with quite very marked HLH, who are extremely unwell, and you do their bone marrow and there's hardly any hemophagocytosis. And actually, in our cohort of patients with lymphoma, we often see a bit of HLH, even if, hemophagocytosis, even if they don't have active HLH. So for us, the biopsies are really to try and find the cause, because until you can find the cause, you're only really just controlling, the top of the fire. You're not really able to put out the fire. So I wouldn't be, if everything else fits and they're presenting like HLH, but the bone marrow doesn't show that much HLH, I don't tend to worry. And I think we still don't know enough about the pathobiology of what happens in every individual patient to know, because I'm sure that there are waves of different stages of HLH will have different appearances in the marrow. We just don't marrow everyone every day and at every time. So it's more to look for other causes. And what we haven't mentioned is that we are fairly aggressive when we biopsy, because we really want to try and find the cause. So we often, sometimes people, some clinicians do push back, because we also advocate for deep skin biopsies, going deep into the subcutaneous tissue to look for intravascular lymphoma. And we have a cohort of around 3 or 4 patients that we've identified where everything else, their PET was normal, there wasn't lymphadenopathy, their bone marrows were negative, but we've diagnosed intravascular lymphoma based on deep skin biopsies. So it is your thresholds change the more you see patients with HLH, because until you get that diagnosis, that patient's just going to do badly.
Right, so I think that makes sense. So in the subgroup of lymphoma with HLH, we tend to, if lymphoma is high on the differential, or if there is no other obvious infection going on in our context, we tend to become very worried with giving both steroids and etoposide. We want to buy some time with IVIG and then get biopsies done, get a PET scan done, and we try to introduce cyclosporin early. I think you've already touched upon it already a little bit, but in the context of lymphoma and HLH, would you have any further insights, sir?
Yeah, so my thinking has changed over the last 5 years, in that we often waited and waited and waited to try and get a biopsy. I'm now much more pro keep giving a dose of etoposide, because if you give a dose of etoposide, you can just make them better, switch off the hyperinflammation, and it gives you this window. Their lymphoma is not going to be fully treated. Yes, it might hide for a bit, but it will come back because it's only a single dose of etoposide. And at least then you've properly treated their HLH. Because until you properly treat their HLH, you might not be able to advance the other diagnostics. And we often, previously we did that. We did everything else and tried to avoid the etoposide. We gave IVIG, we gave cyclosporin, we gave more and more steroids, and you're just, you're running backwards then, because you're not able, because the patient's not really improving. What you want to do is you want the patient to improve so that they physiologically get better and then go on a hunt again. So, both myself and Jess have patients who we have to just treat, and we often just treat with etoposide, maybe a couple of doses, then see them in the outpatient clinic when they're well, and then go hunting for the lymphoma when we then, or hunting for the cause. It might not be lymphoma when things are better. Yes, we also worry about how these patients who are heavily immunosuppressed, which is why we're so keen on good uh, antimicrobial prophylaxis. But um, you know what we haven't done, and some places have done, is they think that this is a lymphoma. They think that it's a lymphoma. They've got bad HLH, and they're just going to treat. And so there are one or two centers who will just treat with R-CHOP because they think, oh, this is going to be a lymphoma. Let's just treat with R-CHOP. We haven't quite got that far. So we've always waited for a diagnosis before we treat. There are one or two centers where we've discussed it and they've chosen to treat without histological confirmation. I'm not saying that's right or wrong, because on their thinking is that this patient is going to die unless we treat their lymphoma. So let's just treat something which treats the majority of lymphomas. We haven't quite got there, but it's the same premise of treating them properly, or treating their HLH properly, so that they live long enough for you to either diagnose them or treat their underlying lymphoma.
And just to add to that, that the stability of the patient during the rounds and rounds of biopsying is also so important. And we've had some problems with bleeding complications related to biopsy. And again, that's partly related to this ongoing cytokine storm and HLH that contributes to that bleeding risk. So yeah, as Sat said, our practice has changed.
Understood. Yeah, that makes sense, ma'am. Now, in the context of lymphoma-related HLH, we've also had a couple of challenging subset of patients where the HLH has preceded the lymphoma by months. And more often than not, these patients have been EBV triggered. And finally, in their fifth or sixth round of biopsies, we have ended up with an NK cell lymphoma. And specifically EBV triggered HLH, some of these patients even have gone on to receive a PD-1 inhibitor outside, and then we receive the patients and we do a fresh set of biopsies and finally ended up with this diagnosis. In the context specifically of an EBV triggered HLH with an EBV triggered secondary lymphoma and HLH, do you have any specific insights into management of these patients? Because at one point we were even exploring the option of whether there's cytotoxic T cell therapies which is going to get rid of the EBV, which is presenting with relapsing HLH in these patients.
So EBV is difficult because it often comes up. So when we do our stem cell PCR, we often see EBV. So we often see a grumbling EBV level or an EBV level that's going high. We also have a low threshold to give rituximab. The risk benefit ratio for giving rituximab is, a couple of doses of rituximab really isn't going to change much. If you want to try and bring the EBV level down, again, it's similar to, I don't think it's going to change the histological diagnostic. So our threshold for giving rituximab to try and control EBV is much lower. when we struggle and the EBV level's not coming down or is continuing to logarithmically rise, we often think, well, is it because it's in their T cells and NK cells? And that's a bit of a marker, and we send it off for the EBV flow. But I think by that stage we would have, if the EBV continues to climb despite rituximab, we'd have already gone to etoposide. So
Got it. So, yeah, I think these patients had received everything, including etoposide, and we kept noticing that the EBV rise precedes everything, and then they end up with another bout of HLH, and we don't know what triggered what. Did the EBV finally cause an NK T cell lymphoma? Was the lymphoma already there to begin with, and they were partially treated, which is probably why we couldn't pick it up. But I got it.
Yeah, I would have thought. Would have thought it was the. I thought would have thought it's always been there. It's just that the EBV is a marker, and your treatment is partially treating the lymphoma, but you've just not found it. So we often use EBV in our EBV positive lymphomas as a tumor marker.
Okay. Deviating slightly away, do you have any experience with using cytotoxic T cells specifically to target the EBV, or do you think theoretically it will help in any of these subset of patients?
So
Because
we
we
don't
use
have.
the IVIG and others, rituximab as well. Sorry, please go ahead.
No, that's fine. So I think we don't have easy access to them. So the Scottish, so in Scotland there is an EBV cytotoxic blood bank, but patients need to have a HLA, the correct HLA type. There is a commercial supply again, which is dependent on their HLA type, but again, that is not available on the NHS. Theoretically, if it's a purely EBV driven phenomenon, then cytotoxic T cells are probably going to be helpful in controlling things. But I don't think it's gonna, if it's a surrogate for an underlying T or NK cell lymphoma, I think it's again going to be a sticking plaster, because I think that by itself, outside the context of a PTLD type EBV positive lymphoma, is probably not going to be enough by itself.
Moving on quickly to the next common subset of patients that we see, it's an infection-triggered HLH. More often than not, we have a very obvious trigger like dengue, which is very rampant in the season here, and we see quite a bit of dengue HLH, and thinking quickly moves to dengue HLH if the counts fall is disproportionate to the phase of dengue there. And in this subgroup of patients, obvious infection and likely secondary HLH, is your approach any different? Do you prioritize IVIG above DEXA or steroids? Would you do anything differently in these subgroup of patients? And how quickly would you think of second line treatment in infection triggered HLH?
Maybe I'll start answering that. So I think the first thing to say is that the data are coming. So there are actually anakinra trials in dengue happening now in various places. So our initial approach is the same. So we would almost always use steroids and anakinra either quickly in swift succession or together. We probably do use more IVIG in the infection-associated HLH, but we hold etoposide in reserve and we never say never. So there are cases of infection-associated HLH, all manner of infections, including complex HIV-associated infections, where we have used etoposide with life-saving benefit. And I think that historically, as a rheumatologist, and probably talking to our ID colleagues too, that we were too nervous about etoposide and not nervous enough about steroids. And I think a long-term high-dose steroids carry such huge infection risk. So the simple answer is first couple of drugs are the same, a bit more IVIG, hold etoposide back, but don't not use it. Use it when you need it.
Understood. I think I'll read out a few questions from the chat box. Dr. Ranjit Kumar Sahu, what is your choice of steroids? Is there any benefit to DEXA versus methylprednisolone, especially in the context of CNS involvement in the context of HLH?
So there are moments when you want CNS involvement and there are moments when you don't. So obviously, if you have somebody with primary HLH with CNS involvement or with a hematological malignancy with CNS involvement, then you might want DEX. Oftentimes, though, you don't want DEX because it causes agitation alongside the agitation you can get from HLH, which is confusing. The second thing is that people are odd creatures, aren't we? So DEX, the down titration of DEX is less easy to do, I think, than the down titration of prednisolone. So we have used methylprednisolone because it has very straightforward dosing. You give a gram 3 days, then as Sat said, a milligram per kilogram of pred, and then you come down in a more efficient, like easy to follow way. And we've just found that people manage to get the steroid down more if they use pred rather than dex. But there are moments when we definitely use dex, when we definitely want CNS. Do you agree, Sat? Is there anything else you want to add to that?
No, I completely agree. So our default has been methylpred to pred. There are some people who try, who follow the HLH protocols where DEX is so central, and so there are people who are already on DEX when they come to our meeting, and I think that that's fine. But we we've I think the initial dose of DEX is not high enough. If you've got a patient who's that acutely unwell with their HLH and actively deteriorating, going to the intensive care unit, you really want, if they're young and previously fit, a gram of methylpred, and it's just a much, you just want to saturate them in steroids just to try and calm their immune system down. And the dex dose in the HLH 94 protocol is high, but it's not as high as a gram of methylpred. So there is, one of the things we find is that if people are on dex, they're on dex for a whole lot longer than they would be if they're on pred, because and it's just to try and get people off steroids. And one of the best ways of getting people off steroids is giving the etoposide. So if you've got someone who's just grumbling and not really improving, one dose of etoposide can be, I'm not saying it's a wonder drug, but in the right patients, it can really switch their immune system off, allow you to come off the steroids. I mean, yes, their counts are going to fall, but they won't have all the other steroid side effects.
Understood. Yes, that is also another thing that generally holds us back, that they're already cytopenic. You give them a shot of etoposide. Now the misery is going to be prolonged longer than finding a.
The misery is going to be prolonged no matter what, but at least if you've given the
Um,
etoposide, you've tried to clear off the
yeah, I agree.
hyperinflammatory microenvironment to allow the normal stem cells to recover.
Understood, sir. A question from the box that we already sent you, particularly with a focus on ferritin and soluble CD25. Um, Raises in infections, goes up in any inflammatory process. What cutoffs are you using, and do you use a serial monitoring? I think that's possible with ferritin for us, not really with the soluble CD25. It's prohibitory cost and doesn't make sense testing it at multiple time points. How do you use both of these, both in any etiology HLH in your practice?
So maybe I'll start and then Sat, you can take over. So the OHI index is obviously useful for giving us a likelihood of this being a we still struggle to get serial soluble CD25s on patients. We do now get serial ferritin, and we do have now agreed a very fast turnaround time in the lab. And I do think that if you're seeing lots of these patients, that is crucial to help you manage, because we often make decisions, really very different decisions from one 12-hour period to the next. So you need your ferritin back really in 1 to 2 hours if you possibly can. And importantly, the lab must titrate it all the way out. So it's no good to say it's more than 6,000 or it's more than 30,000. You need to really know what the number is. Accepting the assays often don't go above 100,000 in all the, the formal stringency that is a sign off, but nevertheless, the same lab doing the same assay, I think it's really very important to try and get the absolute number. So we use ferritin a lot. Um, but one of the things we're doing in our research lab is trying to identify better biomarkers because they're not good enough. And the problem is that when you have, for instance, somebody who develops liver failure alongside their HLH, we just recently had a patient like that who had an HLH-like syndrome and then had a seizure and then developed acute liver failure. And of course, her ferritin went soaring up, but that was from her liver failure, not from HLH. So we need better biomarkers.
No, got nothing to add.
Right. Thank you. Moving on to the next question, I think we will take one from the box. There is a question about from Dr. Nikhil, peri-engraftment HLH in haplotransplants. I think it's a very hematology niche question, but what is your experience with this, and do you do anything differently from HLH otherwise?
So I'm not a transplanter, and we have a dedicated transplanter who sits on our MDT. We tend to manage it the same. It tends to be steroids and anakinra, adjusting the cycle. We do a lot more management of their cyclosporin. So it doesn't really change that much. We try and avoid the etoposide because we're worried about the engrafted cells, and it's just much more fine tuning of what we're doing there.
Understood, sir. One more from the box, Dr. Rohan Halder. Although this is a general question, how would you assess response to therapy? I think it's very relevant, especially when a patient is on multiple drugs and you want to come off one after the other. I think by default, you want to come off the steroids the quickest. But then what benchmarks do you use to try to taper them off the other treatment modalities? And basically, how would you assess response to therapy?
Sorry to interrupt you. Yeah, I mean, actually, this is just such a important and difficult question. I think it's partly about knowing your patient before you start. So getting a feeling for that patient. There's no blanket answer to this question. So some patients, for instance, really their fever is very responsive to the therapy, or perhaps their ferritin is very responsive to their therapy, or the triglycerides or the fibrinogen or something. So it's partly about understanding your patient. And in honesty, what we do is terribly unscientific, which is that we try something, and if it doesn't work, we try something else. And we, as you'll hear from Sat and me banging on about it, we hate steroids. So we always try to come down on the steroid first, but realistically, that doesn't always work. And we often do a bit of this and a bit of that. So we might do the 3 pulses of steroid down to a milligram per kilogram of pred, then down again to say, from 60 to 40, and then try and bring the anakinra down from the maximum dose and to maybe half the maximum dose, and then try again with the steroid. And what you again realize as you're doing it, if you have the continuity to follow the patient over the days, is you start to see those that are very responsive to steroid versus those that aren't. And so far, we haven't really found a good way to do that apart from to try. But I certainly think it's really handy to look at the bloods carefully over the several days of data that you'll have from that patient to try and understand their patterns.
Yeah. So yeah, I think I agree with Jess. I think tracking the ferritin is quite helpful. So certainly we think sometimes we're winning or patients have a degree of stability, but their ferritin will go from 10,000 to 30,000 to 50,000 to 100,000, and you're then even if they're stable, that something's going to happen, and then you just need to have a plan to intervene. So even sometimes the clinical stability versus the biochemical disturbance, it doesn't always go hand in hand. And we're not very good. Sometimes we probably should keep them on steroids longer, and they have a bit of a flare, and then we've got to give them another pulse. The other thing that is important to note is that we disagree, and that's why we all have this MDT with all of the people you saw. There are often times when we all, because this is hard medicine. This is, so much of medicine now is algorithm driven and it's following boxes. The management of HLH is, still one of the few things which is, much more gut instinct and end of the bed decisions made, in real time, and it's hard. And so we often disagree. So our MDT is not a harmonious. I mean, everyone gets on, but it's not all the decisions. Everyone just saying yes. Not everyone just says yes to everything. So often, I will say, oh, I'm not sure about the etoposide, whereas the rheumatologist may be going, oh, Sat, no, we really want etoposide. And I was like, oh, maybe not. And so, and that's what's healthy about trying to bring everyone together because it is hard medicine, and we're often learn. So it is it is difficult. Um,
Yes, yes. I think
I
it's
mean,
very
we need trial data in HLH. I think we particularly need trial data in how to withdraw treatment, actually, which is, of course, a nightmare trial to design. But in our meeting, um, when we're asked by other teams what to do, this is often the most difficult thing to advise on because actually, as Sat said, it changes from the end of the bed. You change your mind. Sometimes more than once a day because you're responding to things that are changing with the patient over hours. I think it's such a good question and a really hard one to answer.
Yeah, I think we spend more, it's very easy to advise how to manage the initial bit, steroids, anakinra, IVIG, cyclosporin, JAK inhibitor, you can say all of that, and, people can pick and choose. But the hard bit is like, well, they're on steroids and they're on anakinra and we've given them their first dose of etoposide. What do we get rid of first? And so that is often the harder question. Now, instinctively, we go down on steroids first, but we have little data to suggest that's the right thing to do. But it's the infection risk which we think, and there's an infection risk with all of those things. But if you look at the cumulative dose of what the cumulative steroid dose that patients with HLH get, it's massive. It is absolutely massive, and that undoubtedly leads to some toxicity.
I understand. And I think it's very comforting hearing from experts that this is how you bounce off ideas because working outside of any clear written protocols is very uncomfortable in medicine. And I think every case of HLH falls into that spectrum of we are already uncomfortable at baseline to begin with, and then we take it from there. A final few questions. I know we are beyond the time slot. If you permit us, I'll ask that. We can go ahead, sir. One from the chat box. Do you use tocilizumab in HLH? And I can clearly see you prefer anakinra over this. Do you use it at all in any context?
So we do use it. We are a little wary of tocilizumab for a couple of reasons. One is that in rheumatological practice where we use it a lot, we don't use it in people with deranged liver function tests, which of course almost all of our patients do. The other thing, of course, is that there is an infection risk with tocilizumab that is more of a worry than with anakinra. And the third is that you can get normalization of the CRP even in the face of sepsis, which is complicated when we're managing secondary infections. There are some data on tocilizumab and sort of HLH all-comers, which also is not brilliant, but there haven't been any proper prospective trials. We do use it in patients who have Still's disease. So tocilizumab is highly effective in Still's disease. So if you have somebody with Still's and HLH and you're just not quite controlling the Still's enough, then we have gone from anakinra to toc, but almost never outside of that situation, apart from, of course, in the kind of post-CAR T, CRS, HLH spectrum thing.
We're also, I mean, I'm sure we'd use it more if it was funded, but one, it's not funded, and two, the evidence base is just not as robust as with anakinra. I think in the post-CAR T cell setting for CAR T associated HLH, it's used very frequently, but if they've developed CAR T HLH, then they're probably IL-6 axis refractory anyway. And it probably would benefit a small cohort of people, mostly I'd have thought with rheumatological driven HLH rather than a malignancy associated or infection associated HLH. I can see that there's a question about which JAK inhibitor. There's no head-to-head trials. There's much more data with ruxolitinib than baricitinib. We use baricitinib because it is probably equivalently inhibitory of JAK1 and JAK2, just a quarter of the price. So for us, if it's a case of, if we were using a drug with more data, it would be Rux. If we're using a drug because we can access it, it's Barry because it's a quarter of the price. But we've had very good, outcomes with baricitinib, which we're writing up now to try and, add to the evidence base.
Understood. I think we'll have one final question. Have you ever recommended transplant for a secondary HLH? If so, what has your experience been in that? And if you can highlight what etiology was there that you thought the transplant was the final solution for a proven secondary HLH?
Yeah, so we have seldom, but we have. So there are a group of often young adults with really difficult to control Still's disease, who have we've failed to control their HLH and their Stills with all the drugs you've mentioned and more. And we have a young adult. Sorry, he's not a young adult. He looks after young adults, a transplanting hematologist in our team called Ben Carpenter, and he has recently transplanted a young woman with systemic JIA, which is now called Still's disease. And there are a couple of people for whom, I can envisage that may be needed in the next year or so. It's not something we take lightly. I can't tell you anything about the transplant because I'm a rheumatologist. Sat may be able to answer a bit more about that. But and I know that it's, I have learned that it's crucially important that we control their HLH as well as we possibly can before going to transplant, which is a tricky situation, right? Because we're only sending them to transplant if their disease is difficult to control.
Yeah, so I think the ones we try and get to transplant are chronic active EBVs. So we've had a couple of patients with chronic active EBV, one who relapsed after allograft and one who never quite got to allograft. We have a cohort of our younger patients with Still's disease who we've allografted. I think we've not had anyone else, but I think it's, for our lymphoma associated ones. I mean, it can be any lymphoma subtype, but it tends to be for the T cell lymphoma ones, you tend to have a much lower threshold of trying to get them to an allograft if they also present with HLH at the same time. But what you really need is, you need pristine control of their HLH prior to the allograft. Otherwise, the HLH will just chew up the donor infused immune cells. And that is where Campath can be very useful. So if you've got someone who's just grumbling with their HLH, you've got a donor, the donor's ready to go. You use Campath in the conditioning arm, really get their HLH under pristine control, and then go in with the transplant. Your chances of a successful outcome is going to be much higher. We would never, we would never. So there's also patients who come to the MDT with this situation about, allografting them and there's nothing else going on. Or, we've had a couple of patients where you've looked and you've looked and you looked, and they're slightly on the, in their 20s. Everyone's looked. They've not found a lymphoma, but they're just deteriorating. So we then switch to managing them much more like a primary HLH, even if the genetics is negative, because maybe they've got a genetic mutation that we haven't identified, or they're already cytopenic, so you might not capture it on the targeted probe or the whole exome or the whole genome sequencing. And in those patients, we have tried to get them to an allograft. So there's a couple of patients where they've had really bad HLH. We've thrown absolutely everything at them. And, we've not, you think they're secondary, the primary screen's negative, but then you go switch from just trying to control it to then trying to think about how can I get this patient to an allograft, because the only real way their HLH is going to be cured and they're going to survive this episode is by getting them to an allograft. Now, the hard thing is, by the time you get there, they'll have been in hospital for so long, their physiological reserve is so poor that they're not the
They're
best
not the best of
transplant.
candidates for transplant to
Exactly.
begin with.
And so, maybe, in that cohort we'll be looking slightly earlier. And I think, the next wave of clinical trials in HLH is going to be very, very useful to try and help guide what we do. So I know, I was just speaking to the people who look after HLH at MD Anderson, and they are trying to bring ruxolitinib early on as their frontline treatment. Not not really based on the Chinese study because there's only 28 patients, but more in-house study. It's an oral tablet, it's good, a good safety profile. So I think more and more people will be using ruxolitinib earlier on if you have access to it. Now we don't, but in other places it may be just something to think about to see, an earlier use of JAK inhibitor may be what is coming in the future whilst we wait for this next generation of novel therapies for HLH to come through.
Okay. Thank you very much. I think I'll stop the questions here, and I think you've generously shared your contact detail as well if we have further questions. I think we are already beyond our time slot. I think it was wonderful hearing from experts in such a challenging field within medicine itself. I know many of these questions don't have direct evidence-based answers for us to easily give them off the top of your heads, and you've taken great pains to answer our questions in details. Thank you very much, Dr. Gohil and Dr. Manson, for joining us and taking time to educate us. Thank you.
Thank you so much. Really enjoyed being here.
Yeah,
Bye.
thanks for having us. Hopefully see you soon.
Thanks. Bye.